Hello, in this video we're going to look at acute gastroenteritis. This is an overview and introduction. Let us begin by looking at a scenario. So a mother brings in her child who has been recently sick. The child's been vomiting for the past 24 hours. The child's been having some diarrhea and also having a fever. Upon examination, you see that the child has sunken eyes, dry mucosa, reduced skin turgor, and has tachycardia. And so your provisional diagnoses, best based on these findings, is acute gastroenteritis. Gastroenteritis is defined as having 3 or more loose or watery stools in a 24-hour period, with or without vomiting, and typically with a fever. Gastroenteritis lasts around 1 week, but not longer than 2 weeks. Gastroenteritis is a common pediatric condition, and the main thing to remember about gastroenteritis is that we want to avoid dehydration. And to avoid dehydration, you have to give fluids. Enteral feeding is preferred, but of course, if the child has more moderate or severe signs of dehydration, a nasogastric tube or IV fluids are used. So for gastroenteritis, avoiding dehydration is critical, and so it is important to look for signs of dehydration. A child can have no clinical signs of dehydration. Maybe the child has some increased thirst and maybe a decrease in urine output. A child with mild dehydration will have dry mucosa membranes, feeling thirsty, have mild tachycardia, and decreased urine output. And then you have moderate dehydration. In moderate dehydration, you have dry mucosal membranes, sunken eyes, some respiratory signs, tachycardia, reduced skin turgor, and lethargy. A child who is severely dehydrated can be said is in a sign of shock. They'll have all the signs above mentioned: mottled cool limbs, altered consciousness, and signs of shock. The main complications in gastroenteritis is to do with underhydration or dehydration and overhydration. Dehydration, the most severe case would be shock. For overhydration, the more severe cases would be cerebral edema and even death. Now let us look at an algorithm of acute gastroenteritis. So again, just recapping, we have a child who has fever, has been vomiting, non-bilious, and without abdominal pain, and with some diarrhea. This is the triad for acute gastroenteritis. The etiology, the cause of gastroenteritis, is mainly viral in more than 70% of cases. It's usually rotavirus, norovirus, or adenovirus. There are also some bacterial causes which make up less than 20%, such as Campylobacter, E. coli, Shigella, and Salmonella. There are also protozoal and helminths that can cause acute gastroenteritis, but these are less common. While examining a child with suspected acute gastroenteritis, it's also important to look for red flags. Red flags indicate a more severe cause. Red flags include severe abdominal pain, persistent diarrhea for more than 10 days, blood in the stools, vomiting without diarrhea, and just being very unwell, having a very unwell appearance. So a child comes into the hospital. What would you first do? Well, you would take a history and examination, and based on this, your provisional diagnosis is gastroenteritis. You then go on to assess degree of dehydration. But it's important that you have differentials in mind, and some good differentials for acute gastroenteritis include causes of increased intracranial pressure, diabetic ketoacidosis, sepsis, urinary tract infections, appendicitis, and other surgical causes of acute abdomen. So your provisional diagnosis is gastroenteritis, and you want to assess the degree of dehydration. They can either be mild dehydration, moderate dehydration, or they can have severe dehydration. During this time, investigations can also be performed, but investigations are not required usually, only in cases of moderate to more severe dehydration. Some investigations include full blood count, EUC, glucose, stool sample and culture, urine analysis, and you can also consider blood cultures for children or babies that have a high fever and have severe signs of dehydration. Now let us look at each of these categories of dehydration and see what the common procedure is. So for mild dehydration, remember fluids is important. So if the child is tolerating oral fluids, you can monitor them and then just discharge them. However, if they are not tolerating oral fluids, you want to encourage oral fluid intake and admit if they are worsening. For moderate dehydration, it's the same principle. You want to encourage oral rehydration, but if this is not possible, there are other options, including nasogastric rehydration and IV rehydration. Again, if they're not tolerating oral fluids and they're not improving, it's important to admit and monitor them. So for these scenarios where oral fluid intake is not possible, it's important to admit and monitor the child to check for vitals regularly. And once they are improving, you can discharge and then follow up later on. For severe dehydration, this is admitting the child straight away. The child is in a state of shock, and it's important to reassess them frequently. Airway, breathing, and circulation are very important in children who have severe dehydration. Circulation include getting an IV access, taking bloods for investigation, and rehydration with IV fluids. And of course, this child will be admitted, monitored, and once improving, you want to encourage oral intake, oral fluid intake, and then discharge and follow up.